Welcome, everyone, and thanks for joining us for this session on the capacity to contain future pandemics in communities. My name is Raj Punjabi, and I serve as the United States Global Malaria Coordinator, leading the President's Malaria Initiative. Outbreaks start and stop in communities. I remember working as a doctor during the 2013-16 West Africa Ebola outbreak. Many of you will also remember this. At the height of the crisis, we were told 1.4 million people could be infected. We were told most of them would die. We had nearly lost all hope. And it was in that moment I remember standing in the rainforest in Liberia with a group of health workers who were responding to an outbreak. When Ebola threatened to bring humanity to its knees, Liberia's community health workers did not surrender to fear. They did what they'd always done. They answered the call to serve their neighbors. Community members across Liberia learned the symptoms of Ebola. They teamed up with doctors and nurses to go door to door to find the sick and get them into care. Thousands of community health workers risked their own lives to help hunt down the virus and stop it in its tracks. A year ago, while serving COVID-19 patients here in the United States, I saw how trusted outreach workers who shared the lived experience of their own communities were more effective than I was as a doctor in persuading and supporting their neighbors to wear masks, to get tested for COVID-19, and to get the COVID-19 vaccine, helping improve vaccination coverage in America's poorest neighborhoods. And through the United States President's Malaria Initiative, I've seen how our partners in Thailand have cut malaria cases by 90%, in part by training 1 million community health workers who have helped the country nearly rid the disease altogether. The science shows that community-based approaches are the most effective ways to save lives during epidemics. The Independent Panel for Pandemic Preparedness and Response, which I had the privilege of serving with, evaluated the COVID-19 response of 28 countries and found those with lower rates of COVID-19 deaths per capita had made greater investments in community health, including in community health workers, determining that they were essential for rapidly finding patients and tracking, isolating, and providing social support to those exposed to the virus. It's no wonder then that in the independent panel's report, a clear recommendation came through that the world must increase investments in community health workers as a key part of strengthening the global response to COVID-19 and the next pandemic. So how can community-based approaches help us better prepare for and respond to epidemics and pandemics? Well, that's the question at the center of our discussion today, and we have a wonderful panel to help us explore that question. Pandemics are global, and so is our panel. Our panelists come from Thailand, from West Africa, and the United States. Each brings deep expertise working in communities to prevent, detect, and respond to infectious diseases. Ramatu Jallo Yorpai, with Partners in Health, is a community health worker supervisor in Sierra Leone. Dr. James Bangura, technical advisor in zoonotic disease surveillance at the Directorate of Health Security and Emergencies with the Ministry of Health in Sierra Leone. Mr. Patipat Susampao is Managing Director with Open Dream in Thailand and is a digital technology expert. And Dr. Jana Mazet, Vice Provost for Grand Challenges at the University of California, Davis in the United States, is an academic and educator. So I want to get started in our conversation with you, Dr. Jana, and then we'll come around the table. Dr. Jana, you have deep experience as an academic and educator, and you have helped countries prepare for and respond to infectious disease events in communities themselves. I wonder, given your background, can you tell us what elements might make up a greater expanded role for educational institutions to support their communities to better prepare for, detect, and respond to outbreaks? How, for instance, has your university played a role in the current COVID-19 pandemic?
Well, thanks so much for having me. And I appreciate everything that PMAC does to highlight the great work that's going on in this realm around the world. My university, as you mentioned, with support from USAID, has been working with communities in more than 40 countries in advance of the pandemic. And those commitments and investments in community engagement and community awareness were incredibly helpful, I believe, in many countries, helping to identify the very first cases introduced into their countries of SARS-CoV-2, and in other countries, helping to actually say, hey, these folks are not infected. But in our own community in Davis, we faced a huge challenge. I think many of you know that in the United States, we reacted a bit more slowly than many other countries did. And I think those community engagement investments, as you so nicely highlighted, were really paying off for places where the communities were really engaged with scientists, educators, and the academic institutions seem to play that really nice intermediary or liaison with communities so often. At home, we were struggling. We didn't have testing. We didn't have surveillance in our community, and our public health system didn't have the resources to bring to bear to actually understand how the disease was spreading and how much we had. And we have a huge university with 30,000 more than 30,000 students interacting with the local community. And so what we did was bring the research that we had been doing globally and with those communities to the home situation, and very rapidly developed a complete surveillance system with our local government and our local public health system that was overwhelmed. And the university itself tested hundreds of thousands of people. We tested in our community every single person, including those not affiliated with the university, could get a test up to as often as they wanted, but we requested people do it about every 2 weeks as normal surveillance if they were asymptomatic, and then certainly whenever symptomatic. And then we took that to the next level and mandated that for all university employees. So we mandated vaccines and masks, but also mandated the testing every 4 days for those who couldn't get vaccinated yet or didn't have had a medical condition or something else that exempted them. And we're still on that track. We're still doing that surveillance. And that with our communities, we're helping all the school children in the entire, we say county, but district, be able to get tested so the kids could go back to school. And so the university was partnering with all the community and the local schools to get every single person tested. So these are the kinds of things that we can't always rely on government to be able to do in an emergency, and we have to pull all the resources that we can together. And our community and our including the university as a part of that community, we really work together, and we called it Healthy Davis together originally, and then Healthy YOLO together because we expanded it to the whole district. So I've seen that power, and I hope that we can be better ready next time, so we don't have the tragedy that we had this time, but always stay engaged and learn the lessons from this one, to stay engaged and not have to build those relationships as much on the fly.
Jana, that's really powerful. I mean, what the idea of a university offering its resources its testing capacity to test those beyond the campus, not affiliated with the university, as you said, to partner with local schools to improve the response. What was behind that decision? I mean, was that an easy decision to make? Why did the university decide to do that?
I think part of it was just wanting to be part of that engaged community, and having the resources when we're all in an emergency, we're all faced with an existential threat. We should all do everything we can to protect each other. And that was something the university could do. We also recognize that if we want to have a campus that was open and bringing students from all over the world to work together and be educated, we had a responsibility to the local citizens to not bring them disease or spread disease and let it get out of control. And we're so proud that throughout this whole pandemic, once we got going with our surveillance and got it up and running, we were able to keep the case percentage down at less than 1%. It was 0.5% in our community, one of the lowest rates anywhere in the world, once we started that surveillance and had that engaged community. So I think we want to be responsible, but we also wanted to do everything we can to help each other.
Well, in the United States, as you know, we have a saying, all politics is local, and perhaps all outbreaks are local as well, as you have pointed out. The response needs to be a whole of society response. Thank you for that, Jonna. Speaking of local and being proximal, and let's turn to West Africa, to Sierra Leone. We have my friend Ramatu Jallo Yorpai from Sierra Leone. I believe you're calling in from rural Sierra Leone. You have deep experience, lived experience with infectious disease. You've also been a community health worker, and now you're leading teams of community health workers, including in responding to outbreaks like the COVID-19 pandemic. What can you share with us from your firsthand experience, Ramatu? What does it feel like to do this work, and what are challenges that get in your way, and what can we be doing to support you, those of you on the front lines, in the face of those challenges?
Yeah, the challenges, these are things that are always part of us, but these challenges sometimes can be handled if we all come together, as you have started already taking the community health workers to the map. We can handle it all together. Yeah, because the challenges we are facing in the communities is because of, and we confront the community with the sensitization only when there is breakouts. And it will be very, it's few people that we accept because there is the outbreak. We're supposed to be there on and on for sensitization for health issues, with pandemic, without pandemic. So it will be part of them. When it already be part of the society, religious leaders, traditional healers, all other stakeholders are involved, frequently on and on with pandemic, without pandemic. Even when we get a breakout, it will be very simple because it's a situation that have been already been used to. But except when there is a breakout, then massive support come for us to push the community and sensitize them. So sometimes the challenges is very high because at that moment, they don't want to listen because they get different information, wrong informations that in their own setting, they believe those information. So for we to overcome, for them to get the right information they need, sometimes it takes us long time, but still yet we never give up, as we are always the soldiers of the community. And we are the trusted people, the community people trusted in us. But we advise, let it be ongoing. Instead of spending a lot of money in buying drugs to offer to people, let's spend a lot of money to sensitize people, to raise the awareness on how people will live positive life. and how people will prevent themselves from future pandemics. So we need to use something that will attract them to give us the attention, because the local artists, the traditional rulers, the traditional healers should be involved in decision making. So that will help us to reduce the challenges, because they always believe that we are paid to go and meet them when there is a breakout. But if this is consistent with breakout without breakout, it will be part of them. They will use to it. We need to be empowered with more community health workers, because the community health workers are so limited for the type of population we are facing. You can see one community health worker having 40, 45 patients to give positive or better job outcome. Sometimes is very hard. At least it's supposed to be at least the highest 20 patients per community health worker. And we're supposed to step in for household role model, not just specific for pandemic.
Ramatu, you're describing you're making a very important point, that we can have all the vaccines, masks, tests, medicines we want, but they don't deliver themselves. It's health workers that do. And you brought up a very important point about trust and the need to be able to have health workers from the community to which you are a manifestation of. I mean, earlier you were telling me about your own experience having lived with infectious disease and then actually deciding to respond to it. Tell us about why you do what you do. Why do you do it? Why do you do this work?
Okay, what I enjoy, what I enjoy doing my CHW job, right?
Yes.
Okay. First of all, I just feel like I should be an impact in my society, because I have been a victim of the circumstances. And without the community health workers, maybe I should not be here by now advocating or representing community health workers. So I believe that the knowledge I have gained through being a community health worker need to be shared to others. I need to give hope to others, because hope was given to me when I was thinking there is no life after being HIV positive. But the community health workers made me to know that there is still better life with HIV positive or with any other pandemic. Depends on the people that come around you. They give you the hope, make you to trust them. So I just feel like I need to pay back. I need to pay back. If I do not pay back, I will never be comfortable, because I think if I should be alive today, I should be a contact point for others to be alive. So that gives me the passion to be a community health worker, with pandemic, without pandemic, with whatever situation, with whatever disease. I can refer, I can accompany, I can counsel. Yes, I can.
Oh no, please go ahead. Sorry, I thought go ahead.
Advocate, because sometimes it's not just for the diseases that are affecting the community, but there is a virus affecting this community. I'm sorry to say that maybe the international world never recognized it, because it does not affect the richer people. The hunger virus does not affect the richer people. So that's why it's not been well recognized. But this virus is one of the viruses that is affecting the poor people, that is leading them to inhuman compromise, that makes them to contact whatever pandemic that break out.
Yeah, so, you're speaking about that epidemic, that the underlying conditions which you understand so well, like malnutrition, that make us more susceptible to infectious diseases like HIV/AIDS, malaria. I thank you for stating that. Let me ask you, before I come to to Dr. Bangura, all of us are humbled by how challenging it is in the time of outbreak and epidemics to earn the trust of communities. How do you do that? What is your secret to earning the trust? What's your advice? Where do you start with earning the trust of the community to adopt masking or to take a test, or if you're an HIV patient, to take the treatment or to come to the clinic? Where do you start, Ramantu? What's your advice for us?
Well, first of all, I want to appreciate Partners in Health because they give us the education. Because without us being given the education, even we can't proceed, because everybody loves their lives. And especially for some of us, because we are exposed. But because of the education is being given to us by Partners in Health, they give us the pillar to stand on, to pursue the situation on ground. Like we started by making people to understand the risk and the benefits.
Mm-hmm.
Yes,
that's really helpful. Yeah,
yes,
yeah. I think what I'm gaining, what I'm hearing you say, if I've got it right, is you have to start by, you said the word training. So to stop thinking of communities simply as recipients of our services from the health system, but actually as agents, as part of the team in delivering those services. And you then said you have to explain risks and benefits, which, as a doctor or as a public health policymaker, that's also what we're trying to do, is explain risks and benefits. And I think what you're telling us is that also can happen door to door, not only in the media, not only from an office or a clinic, but actually door to door. Thank you, Ramantu. We'll come back to you. Dr. Bangura, you also are in Sierra Leone. You have a different role, in a critical role in surveillance. There are many surveillance officers and those running surveillance around the world. They're trying to get better at doing that, better at detecting and responding to infectious disease outbreaks. I wonder if you could tell us, and perhaps even give an example of how surveillance data can be used by the community for better detection and response, and how that results in better efficiency or effectiveness. I know you have worked also during the Ebola outbreak in your country and during the COVID-19 pandemic. So give us an example. How does better surveillance data help us have a more efficient response to these epidemics?
Yes, thank you very much. Thanks for the opportunity to share on this forum. Surveillance, we all know events, outbreaks, they start in the community. They occur in the community. What we have learned over time, especially in the recent two epidemics and pandemics we have handled, first with Ebola and now with COVID, that we need to get the communities to a point where they are equipped to monitor what happens at the local community. Communities are the first level of surveillance. So your system, for us in my role from Ebola to this point, is developing a system at that community level where they are capacitated to monitor what happens in the localities. And this involves increasing their knowledge on what they should be looking for, what's abnormal, what's really normal, and what's indicative of something that they should take to the next level, events that happens in the various localities, and empowering the local authorities that are there. We've spent time and then helping them to get to that point where they monitor those occurrences. They play a very key role in preparedness as well. We have spent time over the years to get them to the point where they know what to report to the next level. Taking, for example, in your intro, you mentioned the role of the community health workers in Liberia. The same in Sierra Leone. prior to the Ebola outbreak, the concept of community health workers wasn't that really eminent, as when we saw what the Ebola virus was doing within the communities, we got to a point that we developed what we called community monitors, and that eventually served as the beginning of community-based surveillance that is being rolled out now. And these were identification of trusted community leaders who will serve as the eyes and ears of the health authorities. And these officers were equipped on what they should be looking for and what they should be listening to, and then what they need to do to the next level, especially to the health officials. So we got them to that point that they served as critical mass to identifying, when I was seated, beginning from the first case that we had in country, where between the borders of Sierra Leone and Guinea, right in the community, beginning with a community, a tribal leader. The event was happening there and nobody knows what was it. For them, it was normal. So until when the first responder, I happened to be among the first to engage in them and then enlightening them that this is abnormal. This is something that you should have reported to the next level of the facility that you have. And then they started giving us clues and links of which eventually for us as epidemiologists were able to track to what extent and then travels and linking them. So they play a very critical role in identifying exposures, exposed groups. And then we have seen at that point that they served, during Ebola specifically, they served as ambassadors for us. They also serve as the very first point from the community itself and then to the health facilities, especially the peripheral health unit level, the lower level, linking the community with that health facility and the health facility to the next level of health systems reporting, maybe to a district or county, as other countries may call it. We had them also serving during that outbreak, like increasing alertness. So they increased the alertness during Ebola when we had bylaws. We had communities setting up that X, Y, Z should be monitored, like travelers coming from other localities. Well, Ebola at that time, we had the travel linkages that we needed to monitor, one, to keep your community safe. So they were alerts. So they were tracking travelers. They were tracking like strange visitors that are coming within. The alertness was there. And they stood up as, okay, we have to protect our local community. And then they took it, and then there was ownership among them. We saw that travelers were being sent to us, oh, this individual came in, we don't know this person, is not part of us. And then you saw like enforcement of public health regulations, the measures that we had instituted. They were like, we saw the chiefs, the local authorities took it on themselves that, yes, this needs to be done. And they became the watch for everything that was happening in their localities. We went towards the end of Ebola, we transitioned them into the routine health systems, whereby every health facility was attached like at an average of 5 health workers, community health workers per facility. So these are the ones that are linked to every peripheral health unit to monitor what happens, what we refer in Sierra Leone as a catchment population. Every peripheral health unit has a population it serves. And in those various populations, it also have like every health worker is attached there to monitor events that are notifiable. So increasing their knowledge. So they monitor, oh, this is happening in this locality, and brought that forward. And then that's served as a platform when we had the first cases, when COVID came in. And then when COVID came in, and the rollout of community-based surveillance system was already ongoing. 9 districts districts out of 16 health administrative units in the country were already implementing the community-based surveillance system, which came in during Ebola as an initiative to find cases, to find contact, to find exposed groups. And then we ended up utilizing them as health informants. We ended up utilizing them as point of entry to the various communities. We ended up having these communities as deliverers of interventions that were developed from the national level or to the district level and to the community level as well. We had them, they play a role in monitoring these localities at the same time. And then we had them utilizing, what is a popular toll-free system that we have in the country. We refer to one service, a hotline toll-free system that they increasing the alertness that look for this, and then please call immediately. This one is a toll-free, it's a free one. You just have to initiate the alerts, and then the health workers respond immediately. We have them, they served as contact tracers as well, tracking contact that are exposed groups. They serve as individuals that are monitoring them, then reporting to the next level. They utilize that, this individual that we are monitoring, they trigger that, we need to respond to this individual. So we have seen them really becoming a critical mass in the surveillance system. And even within COVID, we had them as mobilizers, mobilizing communities, taking the messages of how do you keep your community safe, how do you protect the rest of the other community, onto even vaccination aids. Now that we are promoting vaccination across all levels, they are there to serve as ambassadors for those mechanisms. So
James, you're telling us, I mean, you've given us such rich examples. They're messengers. Community leaders and health workers can be messengers. They can help with event-based notifications, speeding that up. They can issue alerts in their community and educate their community about vaccines. There's as a fellow epidemiologist, we're not known for our humor. And so I've heard there's a joke that if you've seen one pandemic, you've seen only one pandemic. It's not much of a joke, actually, but I've heard it framed that way. And I think what that phrase means is that while every pandemic is different, we may use similar muscles or systems to fight it. And I think you've just given us a great example of how we build muscles, in this case, the muscle of community surveillance, community messaging, community education. We build that muscle by actually using it. You built it during the Ebola period, and you're now using it again during the period between epidemics. You said routine event-based surveillance, the community's involved in that. And now because you kept that muscle strengthened, you're now able to deploy it again during the COVID-19 pandemic. So thank you for that. We'll come back to you, and thank you for your work there in Sierra Leone. Let's come to Thailand. Mr. Padipat, I believe you're there in the room physically. You have extensive experience in early warning systems. I want to talk to you about how data from the community can help inform early warning platforms, and how that data can be linked to national and global platforms for alerts, as James just spoke about, and for response. So tell us about that. What information? How can we ensure that information moves in both directions, from and back to communities, for situational awareness, for risk assessment, and ultimately for action?
Yeah, no, thank you very much. Sawadee krap, and good evening, everyone, for inviting me here. And I would like to say that the work that we are doing in Thailand right now is called PODD. It stands for Participatory One Health Disease Detection, and it's a collaboration project under Chiang Mai University in Thailand. And what we want to focus is we want to focus on the surveillance effort in the backyard farming, which historically been ignored. What we are trying to do, we're trying to turn the farmers into the disease detectives and hopefully stop the future pandemic before it happens. So When we talk about the flow of information, there would be two ways of information. One is how can we get the information from the community and make the decision based on that information. And two, the second flow is how can we mobilize the actions to that information. And what we were trying to do is for the first one, getting the data from the community to the system is to so we need to have a volunteer in the community level, and our volunteers could be technically could be anyone. There doesn't need to be the health expert, and we equip them with the application that we developed called PODD application, and basically it looks like it's similar to Instagrams without filters, and we train them what to spot, what to look for, and what kind of event that should be reported, and that's all we train. Most of them were housewives and mechanics, so basically everyone can be part of the volunteers and network. And at first, when we start PODD in 2014, the community was skeptical that when we trying to do like surveillance in the community, the only outcome they can think of was that we're going to call the animal if they're disclose the animal sick and dead in the backyard farm. And we understood that feeling. So because like traditionally, the cheapest way to contain whatever community outbreak happen is to kill them all. And PODD differs itself from the traditional system because we try to be flexible when getting data. Of course, the word surveillance sounds very scary to the community members, but still we try to go beyond that by collaborating with local government to, for example, to provide veterinary care. So in the end, when the farmer trusts and count on the system, they participate in our surveillance system, and as is called in the name, participatory One Health disease detection. And the second data is when we receive the data from the field, how can we mobilize actions based on the data that we receive? And it's actually very straightforward because when the reports came from the field, and if it matched our predefined criteria, PODD, the system will automatically send the notification directly to the appropriate actors. For example, primarily PODD will send we call it preliminary guidance to the reporters and the nearby volunteers, so they can start doing what they could do. For example, like start separate the sick animals from the herds, or trying to do some basic things that they could do. And if the event matches the suspected outbreak definition, PODD will alert community leaders and also like surrounding villages, local governments, and also livestock officers. And in some cases, such as rabies, we also notify the public health officers. So what we're trying to do is to like send the right information at the right time to the right person. So we want to ensure that the information flows to the right person and at the right time. And by doing that, by enable the community to be able to respond, even the basic things to the animal sick and dead events, and it can speeds up the time to detect and time to respond from traditionally multiple months into a few hours.
Well, I mean, here you are. First of all, congratulations on picking an acronym POD, P-O-D-D. That's easy to remember. But this participatory One Health disease detection platform, I believe you received the grand prize from the 2021 Trinity Challenge for this very powerful system you've talked about here. How have you seen, when you measure the impact of that platform? Is it speed in alert? Is it the speed in detection that you're measuring, or is it and how can you make sure that the events that are being reported, you mentioned, are accurately matching? Well, let me actually ask you a separate question here. So you said that the alerts you get are matched to a case definition, and if that case definition is matched, you send out alerts to community leaders and others to respond to outbreaks. How often is that information correct or accurate?
It's a very good question. I would say most in the back end, the system, of course, we're trying to automate everything as much as possible, but we still have human to monitor it. So sometimes there were cases that our volunteers were lonely during New Year Eve, and they sent some like Happy New Year photos of their chicken, that kind of thing. It could match the definition, but we use multiple parameters to determine like when to send the alert. So for those like lonely Happy New Year cases, we have a human to look into it, and we have a human to call to confirm, are you really drunk, or like is this really the case? Those kind of actions helps us fine tune the case definition that we defined in the system. And I had to say, like, PODD is still evolving, so of course there would be some novel early outbreak that we couldn't detect, but at the end the system is set to have a human in the background to check it, and those humans can be our PODD team members, or even the community leaders that some community they appoint someone to look into the data regularly. So we have that human layer of information verification, so that could be fine-tuned.
That's really interesting, because I think you're, like most parts of public health, when you pair high tech with high touch, the technology with the humans, you can get a better result than if you try investing in either one alone. So thank you for that insight. Let me come back to Dr. Jana. You know, we've just heard really interesting examples from each of you of current actions, current community actions, community-based approaches for preparing, detecting, responding to epidemics. We've heard universities who are opening their doors to make testing available to their own local communities. We heard from Ramatu about the role of trust and leveraging the community's lived experience to enable that trust during an epidemic. We heard from James about the role of community health workers in event-based notification and sending alerts, using that muscle both during epidemics and during periods in between epidemics, so that we can have more efficient systems when a pandemic emerges. And we just heard from Patipat about the role of technology in enabling all that, not only for human health, but for animal health. Dr. Jana and colleagues, I want to talk about the future. What do you think is important in terms of future actions? What improvements can we make in epidemic preparedness and response at the community level? So let me come to Dr. Jana first, and then I'll go to Ramatu, James, and Patipat. So Jana, if you could give us a sense, you already described a very strong role for educational institutions and communities. You're also a One Health expert. Looking ahead, how do you think such institutions, educational institutions, could address some of the sectoral silos we have when we're trying to work on zoonotic disease prevention and response?
Yeah, well, and to go back to your sort of preamble there, I think the most important thing we can do is be prepared, equip and learn, and have all of us, every member of the community at every, part of that community be aware and be vigilant, be watching and be prepared, and know the science to the extent, not everybody needs to work in a research lab, but everybody needs to know who to trust as a informed party that can explain what's happening with the science. And if you don't build that trust, just as Ramatu said, in advance, and you don't educate in advance, you can't get there. So I just feel like everyone has a responsibility to participate and break down the silos, trust each other, and be part of one community. And I think, again, another USAID example that I'm proud to have been affiliated with is the One Health Workforce Next Generation project, which is taking the universities and building university networks specifically to break down those silos, and then to work with governments and every sector of society to have the information when they need it. And that's a preparation, because if we're all trained and understand that we have a group to go to, and we have good, solid resources that are keeping track of all this information, and we can trust them, that we will be doing much better. But as far as breaking down the silos, you just have to bring the people together. You have to invite them. I mean, there are a lot of groups that want to and can bring huge resources and ideas and intellectual horsepower to these problems, but they don't get invited to the table. And I think some of the great examples you've heard from Patipad and James are also really highlighting that it's the mutual respect. So you mentioned One Health, and I have been an advocate for One Health for more than 20 years. And I truly believe in the approach because it is inviting collaborators from all disciplines to come to the table, and then respecting each other so that you can move forward. No discipline, no hierarchical structure puts any person above another. We have to be one community and work together. So I'm thrilled to tell you that at UC Davis, we're now taking that One Health approach and going beyond pandemic prevention and preparedness, going beyond antimicrobial resistance, which are the two areas where the One Health approach has been very useful so far. And we're gonna ask people to get involved using this exact same paradigm to attack the world's wicked problems, like climate change, like poverty, like food insecurity. And I do think that that's the future, and that academics, like governments, have been very guilty of siloing up and just going off and working in their one little piece of the pie and not looking holistically at the big picture. And I think that's really what we need to change. And I think together, this community, the PMAC community, that's really engaged with universities and governments, can make that happen. And the One Health Workforce Next Generation has started a global One Health Academy with the resources available online, as well as supported the amazing networks in Southeast Asia and Africa, the One Health University Network. So I feel like the future is bright.
Well, it's such an interesting point about when you invest in community networks, agents of change, including as One Health workers, it becomes a force multiplier for taking on other challenges. What an interesting example. Thanks for sharing that. Let me come to you, Ramatu, in Sierra Leone. What looking ahead again, to better prepare for and respond to the next outbreak, what type of investment is needed to ensure better community trust and cohesion?
Yeah, that is a very good one. First of all, patient-centered approach. Recruit, train, and equipped community dwellers to provide education to their people. make referrals also accompaniments for clinical sick patients. That will be one step. The second step, people that are inhuman compromise should be capacitated for self-reliance skills that will keep their mindset focused, not by spreading the disease to others. Because if every day the disease is being spread to others, that makes we get more population with inhuman compromise. Any breakout that comes, they are exposed. So to avoid that, those people should be capacitated with self-reliance skills, with the knowledge of more and more sensitization, preventive measures, day and night, social media, local people in the community that the people are looking up to, like the local artists, the Mami Queens, the chiefs, the traditional healers, the traditional rulers. All these people supposed to be involved in decision making, not by just implementing after decision has been taken. So I think that will help. The other one here is health facilities should be equipped with staff, and there should be, there should be space system for whatever type of situation to be accepted in the facilities, not just specify on base of pandemic, people affected by the pandemic. Because if every type of disease have the provision and the facilities, that will reduce the stigma rate. And because of the stigma, and because of, just like I said the first time, the hunger virus, people, even if they have the signs and symptoms of COVID, they are afraid to come to the facility because they don't want to be quarantined. Because if they quarantine, what they hope, especially for the women, because in Africa here, most of the women are the breadwinners in their homes. So for you to leave your 6-7 children home because of you have signs and symptoms of COVID, to report yourself to the facility or to accept to be in the facility or to be quarantined, you find it difficult because you are thinking what those children will be survived on. That's why we find it very difficult. But if these things that I outlined here is being put in place, I think it will help us for we to overcome. And the social support. People deserve social support. Not just when there is pandemic. This is the issue, because when there is pandemic, whatever you say at that time, they say you are paid to say it. But this should be often. Community health workers should be part and parcel of every decision making concerning health, because we are in the community, and these people trusted in the community health worker even more than the doctor. The patient will talk to the community health worker what the patient cannot talk to the doctor, because they believe the trust we give them, the confidence, the hope, last minute will always be there for them. Even when COVID break out with all the fake information and rumors, but we were still there making them to get the fact about COVID. So with that, we are able to overcome. And sometimes the higher part of the program, all is being handled by men, where equity comes in. Only when there is time for volunteer issues or taking 90% risk, women are pushed at the front. So all these things are part of what is affecting the community, because you call people, we even have some community health workers who are not being paid. The government community health workers or people who volunteer in the community to be part of us, but they are not paid. So all these people are supposed to be involved. We need to be capacitated. And in whatever donation the world will be giving for community issues, let it be direct to the source. Because sometimes it does not come directly for the use of what the requests have been made, because the source of the community project are not involved. So that's why sometimes you feel like you are supporting the communities, but every time we have challenges, because sometimes the support is not coming directly to the people that's supposed to implement the support to the right people.
So I'm hearing you say, Ramatu, with the passion and power of someone who's, again, proximal to the problem, three things. One, consistency. It can't just be when there's a pandemic that you decide to invest in the community. There has to be investment before, during, and after. I'm hearing you say holistic. That has to be paired with investments in clinics where people will go to get care, and also in holistic responses that address the social and economic challenges that people face as well. Because, as you said, if people need to isolate and their family's hungry and they're the breadwinner for their family, that is a much different set of circumstances than, say, when I have to isolate here because I can keep working from my laptop if I need to. And the third point you just made is nothing for us without us. Bring the community to the table to make these decisions in the design of these interventions, not just as recipients. Thank you for that, Ramatu. James, over to you. Let's look again at the future. We know that future investments in surveillance should be in large part focused on supporting early detection and response for infectious disease events. You live that every day. But if you could be even more specific and use an example, what kinds of innovative approaches or technologies can be used to improve data collection and dissemination in the future?
Yes, thank you very much again. I will use the real time when Ebola struck West Africa, Sierra Leone, be more specific. We never had a toll-free. So it's the features will look into strengthening the two components of surveillance, the event-based, which will monitor like events circulating around from the community level onto the highest level, and then as well as also the indicator-based surveillance. But let me take with investment that needs to really be looked into event-based, because that's what happens in the community. And that's where it all begins. We introduced in Sierra Leone a hotline that I mentioned earlier, a toll-free system, which we had mechanisms, lessons learned from Ebola. These are lines that are being used by the lowest community to notify occurrences that happens. Fast forward to post-Ebola, we had these to be streamlined where we could monitor mortalities across all levels. And then, like in the capital city in Freetown, every death should be reported. And when we monitor the hemorrhagic fevers, so when they are reported within this toll-free, that's a really critical data that we analyze every week. I see it at national level with what we call the Epidemic Preparedness and Rapid Response Group. We meet on a weekly basis, and we review this data that comes from that toll-free system and the investigation that was done, the categories of all of those alerts that are coming. That is a critical piece to invest in. And then to able to send that down to the communities and promote its utilization as a critical component of data collection, which we're using. I don't know for other countries, this has proven very, very efficient for us in Sierra Leone. Another component in the event-based that is worth looking into, my colleague from Thailand did mention, is the utilization of mobile apps. We have in Sierra Leone, we are rolling out the ACBDS, electronic case-based disease surveillance system, wherein for every event that is being reported, for example, if it's a mortality, so it's related, it meets a particular definition of a case, and then that one should be captured in there. So in our One Health system. So when we were developing, in my role as a technical advisor for Zoonotic, we were building an early warning system using the One Health approach, where we have community health workers, and we also have a group that we refer to community animal health workers, which monitors what happens in the animal world, and another group that monitors what happens in the human world. Bringing those two together, there was the need to have an app or a system that is interoperable and that is sustainable. Probably we see mechanisms wherein like sustainability of some of those mobile apps devices becomes a problem. And then, so when we're investing into those, can we think about apps or the technologies that can work offline? Because we want to have the access that communities can access it, and they can just use it, and then they can send in the data that we need, because we need the information so we can take the action. So we are critically looking at.
So deeper investment in event-based surveillance and a routine, if I get you right, everyday routine community event-based surveillance, and then to leverage technology to strengthen those systems, not only for human health, but as you said, for animal health.
Correct.
Yeah, thank you, James. Thanks for the work you're doing as well. Mr. Patipat, you are, get the last word in the country that's hosting us. So over to you. I want to ask you about your background in early warning systems. Tell us about you were explaining the role of your technology in detecting animal health events. How can we get better in the future in leveraging such platforms for situational awareness and risk assessment and ultimately action?
Yeah, thank you very much for the question. I think every panelist have mentioned what I want to mention already. So I would like to just put the last drop to the conversation, which is, I think the most important part from my perspective, I don't think the technology would be the major issue right now, because it has been proven in many settings. In Thailand, it's been tested in the rural area, which like unstable internet connection, those kind of thing. I think it is quite okay to look into the other challenges. And the most important thing that should be start thinking of in terms of collaboration for preventing, let's say, COVID-25, 26, I think, is to look into One Health and think about the future pandemics. It could come from many factors, and adapting One Health approach could be useful to prevent that. The second thing is I think like there would be two ways on putting this. One is first, the policymakers. When policymakers thinking about public health policy or like disease policy, those kind of things, it would focus mainly on human, and also when we talk about public health, it has a public word inside that, but I believe like the public has not much opportunity to participate into the policy making regarding to the public health. So having back to the public health would tremendously improve the situation of not only disease surveillance, but health promotion. Every one of us has been taught about the determinant of health, which is like go beyond biology. Yeah. So I think
I love that. But
really
I love that message. I love that message, and what a great way to let's put the public back in public health. I think that you've really I think captured maybe the essence of our panel discussion today. And I want to thank you for your work. Congratulations again on winning the Trinity Challenge. I want to thank Jana for your work and UC Davis and what you're doing to leverage university resources to as an asset for the community. I want to thank Ramatu for your everyday work to serve your people in Sierra Leone with such passion and zeal. And James, for your such critical work to build national systems of surveillance that engage the community. I'm going to wrap us up here and with just a few takeaways from the session. Number one, you have made very clear that the best emergency system may not be an emergency system per se, but an everyday system that is responding and can be surged during a crisis. You have taught us, I think, today that perhaps one of the most effective ways to fight today's pandemics and future pandemics is to actually is to leverage those systems, to build muscle by using muscle, whether it's systems for surveillance, whether it's hiring, training, and equipping community health workers, whether it's building next generation One Health workforces, or leveraging technology for participatory engagement of detecting animal health events. I think the second thing you've taught us today is that we have to bring services to people, not wait for people to come to services. We have to bring services to people, not wait for people to come to services. And I think you just made that point very clearly, Patipad, with the fact that the first word in public health is in fact public. Ramatu spoke about the need to engage communities not as simply as recipients, but as designers of our work. James spoke about the need for health workers, community workers to be actively part of surveillance, not passively part of surveillance. And Jana spoke about that this wonderful vision of leveraging networks of community agents built in one crisis to respond to other crises. And I think the last thing that perhaps is implicit is a lesson that wasn't even said or mentioned, but is true nonetheless by virtue of you showing up here, by the virtue of PMAC putting a session focused on communities, is that medical breakthroughs like vaccines, tests, treatments, while always going to be necessary in responding to epidemics, are not sufficient. Medical breakthroughs are not enough. They don't deliver themselves. They cannot persuade people on their own to use those interventions. It's people who do that. And we have to invest in people as much as we do in things. We have to invest in staff as much as we do in stuff. We have to invest in humans as much as we do in technology if we're going to be able to contain and effectively prepare for and respond to pandemics. So I want to thank you all for your engagement today, for all of you listening. Thank you again to everyone for everything you do. Stay healthy, stay strong.